Most acutely ill and injured children will first go to emergency departments that are not part of a children's hospital. Difficulties in getting the right resources and training have been identified as known barriers to providing the best possible and most consistent care in these settings. With this, TREKK launched in 2011 as a knowledge mobilization network to address these gaps. We are very fortunate to have Dr. Karen Grip here today to discuss influenza with us. Dr. Grip is a pediatric emergency physician and associate professor within the Rady Faculty of Health Sciences at the University of Manitoba and section head of pediatric emergency medicine and medical director of the Children's Hospital Emergency Department. Dr. Grip received her medical degree from Johns Hopkins School of Medicine in 1996 and completed her pediatric residency training at Johns Hopkins before obtaining additional training in pediatric critical care at Children's Hospital of Colorado. Since coming to Winnipeg, Dr. Grip has served as a pediatric PGME co-director and as chair of the National Canadian Pediatric Program Directors. She remains very active in medical education with the Royal College of Physicians and Surgeons, and Dr. Grip served as the chair of the College of Physicians and Surgeons Child Health Standard Committee and as a master faculty for the simulation course, Trauma Resuscitation for Children. And now, with further ado, I'll turn it over to you, Dr. Grip. Thank you for being here today.
Yeah, well, thank you for that. And thanks to all of you for joining today as well. This is the third time you've seen my face during these sessions, and I promise that you will meet other pediatric emergency physicians from our group. I'm really quite excited about the next few sessions. I find that when you see our faces, it's nice that so often we talk to you on the phone, but it's really nice sometimes to see faces and kind of understand what we do, and we're all part of a big team, of course. So one of our jobs in children's emergency is to be that tertiary referral center responsible for the care of children from throughout our very large catchment area. And while we may be the ones highly trained specifically in pediatric emergency medicine, we also know that the majority of our patients present to you first, to nursing stations, to walk-in clinics, to general hospitals and emergency departments, to EMS providers. You all do an amazing job caring for our young patients, and there's much that we can learn from you about managing patients with sometimes very limited resources. So our job is not to tell you what to do, but instead, I strongly feel that we as pediatric acute care providers have that responsibility to share our knowledge, and in a collaborative way, we can help each other. I have no disclosures. So my main objective today is to increase the influenza vaccination rate in pediatric patients in Manitoba and truly in all patients. So as emergency providers, we do need to recognize sick children with the flu and their complications. But it's also our job to advocate for the prevention of influenza. While it would be great to have one series of flu vaccines which work lifelong, that's not how it goes, as we know. And every year we need to try again and again to get folks vaccinated. There's also a bit of vaccine fatigue after this recent pandemic. So really trying to get uptake of the flu vaccine as well is so important. So our goal is really to understand and utilize best management practices for the assessment and management of pediatric influenza, to understand the burden of influenza infection in children, to learn about some complications and how to recognize and manage them, to provide information on how to educate patients and families, and to increase awareness and uptake of influenza vaccination. The reason I'm doing this talk in September and not in March, for obvious reasons, right? You know, we're just looking down the pathway of influenza. It's out there, it's coming. We don't know exactly when, but we also know that vaccines are on their way for Manitoba. So hopefully by the end of September and into October, we'll be able to start vaccinating. I also know that another large population at risk for influenza complications is the population with our over 65-year-old citizens, right? So today I'm going to focus on children because that's my population, but I know most of you take care of adults as well, so including our seniors. And so much of what I say today applies to them as well. I've structured today's session around the myths our patients hear concerning influenza. And again, I know we're all medical providers and we understand that these myths are not true, but by discussing them, I hope to provide some structure to this talk, but also some support as we educate our patients and the public about this disease. I'm definitely not an expert on influenza, but I am a fierce advocate for patients and preventing illness as much as possible. So to summarize and to borrow a phrase from our colleagues across the ocean, give flu the jab this winter. Right? And if there's one thing you take away from this talk, it's the need to immunize everyone against the flu, not just those who have medical conditions, but every single person. So let's start with the first myth, that the flu is not serious. Let's talk about the real facts. But first, let's talk about Adam. Adam is a 4-year-old boy with acute onset of fever to 40.7, chills, body aches. Past history is significant for mild asthma, but he hasn't needed puffers in over a year. He presents, his SATs are 87% on room air, he's wheezing, he started on the asthma care map and is admitted to the hospital. Okay? So we can launch our first poll. And as we're doing that, the poll will ask, which of the following are risk factors for influenza-related hospitalization? And you can choose all that apply. I like the fact that everyone's picking asthma for sure. That's great. Another 5 seconds. Okay, that's awesome. So we'll just share the results. Asthma, 100%. Obesity, diabetes, age less than 5 years, leukemia, nephrotic syndrome. The answer, which I didn't put as an option, is all of them. So all of these, plus others, are risk factors for influenza-related complications. So let's go back to Adam. So what's happened with Adam? So he was admitted to the hospital. He develops increased respiratory distress, right? He started on BiPAP. He's intubated for respiratory failure. He develops a ventilator-associated pneumonia, has some challenges with oxygenation. So he switched to high-frequency oscillated, or the oscillator, the high-frequency oscillatory ventilation, and then requires ECMO. On ECMO, one of the risks is hemorrhage. He has a hemorrhagic stroke. He recovers from his influenza, but he now has permanent hemiplegia. So let's talk numbers, right? So this slide shows the weekly rates of flu-associated hospitalizations from the CDC. So these are US numbers, but they're similar to Canadian numbers. The peaks you see are the past 6 seasons. This is not all the people who had the flu or showed up to emergency with flu symptoms, but people who required hospitalization because of the flu. So there are 2 striking messages on this slide. One is the seasonality of the flu, which is not a surprise to us. But the second message is how severe the last 2 seasons were. We thought the last pre-pandemic year, 2019-2020, was bad, one of the worst we've ever seen, but the last 2 years were even worse. And of course, there are other viruses out there, of course. In children's emergency, we also deal with RSV, as well as the other viruses. And I won't mention COVID, but obviously COVID is now a contributor as well. So the green line overlying the blue lines, the green line shows RSV hospitalizations over that same time period. So not surprisingly, these infections happen in winter also, and usually around the same time or within a few weeks of the influenza pandemic. And when they peak at the same time, it can be very, very challenging. And then the flu season, I'll just mention in 2023, which is the winter of 2022 to 2023, affected younger patients much more than usual as well. So, and it's not just COVID. The flu also causes pandemics as well as epidemics. So we're all familiar with the seasonal epidemics. Influenza A, most common, peaks at about 2 to 3 weeks, and it lasts about 2 to 3 months. Influenza B peaks later, usually smaller numbers, but they can be more severe. And there have been some pandemics as well. Right? One example is the Spanish flu pandemic, 1918 to 1919, which was with the influenza A H1N1 virus. It caused 500 million infections, 50 million deaths. And our most recent pandemic, which also with an H1N1 virus, which was 2009, resulted in 285,000 deaths. And most of those deaths were in the younger population, so under 65 years, which is actually different than usual. So I have a question. This is not a poll, but just kind of put it in the chat. Does anyone know why it's called the Spanish flu? And if any of you are my residents, you'll know I call this a smoothie question. If you get it right, you get a smoothie. Just put it in the chat if you know. So Melissa, yeah, I assumed that as well, and until I did a little bit of a deeper dive. So the war exactly, it actually happened during World War I. And because of the kind of embargo, a lot of the media were not allowed to operate, like of the countries who were actually involved in World War I. So the only media that was allowed to get out there was from countries that weren't involved with the war. Spain wasn't involved in World War I. So their media was able to communicate what was going on. So everyone assumed, because they were only hearing about it from Spain, that it originated in Spain, but it really didn't. So that's why they call it the Spanish flu. That'll maybe a Jeopardy question someday. So let's continue to talk about some more numbers. So worldwide, what are the impacts, right? The World Health Organization estimates that there are 1 billion infections a year with influenza. So that's 1 in every 8 people on this planet. There's 3 to 5, of that, but 3 to 5 million cases of severe illness, and up to 650,000 deaths. So quite significant. In the US alone, just in the 2019-2020 season, 18 million medical visits, 410,000 hospitalizations, and 24,000 deaths. Let's bring it to Canada, right? The most recent season, we had this is a 2023-2024 season. There were 42,000 influenza-associated hospitalizations. And in the year prior, half of those were in children 0 to 18, and then the highest rate in the very young children. Again, in fairness to the seniors, I should mention that the numbers among the senior population are also very high. Influenza disproportionately affects the very young and the very old. Not that I'm saying 65 is very old, especially as I'm getting closer to that number every year. But within that population, the risk of hospitalization is much higher and associated with increased frailty. So the older you are, the higher risk. So let's look at children's emergency numbers. Let's kind of bring it home. I mean, you'll notice that the peaks and valleys of influenza in children's emergency are quite similar to the previous graphs. And you can imagine what December 2023 looked like in our emergency, and you can see this tall spike right here. So we're a department built and staffed for 100 patients, and we were seeing over 200 patients a day, and some very sick patients. And this was very similar to all across Canada. I know you saw many patients of all ages with influenza as well. So speaking of flu A and flu B, maybe this is a good time to talk about all those, H and N numbers and what they mean. So these represent the antigens on the influenza molecule. So we divide influenza A into subtypes. The two groups of antigens are H for the hemagglutinin and N for the neuraminidase. There are 18 types of H and 11 types of Ns, but in humans, really, it's just 3 and 2 respectively that affect humans. Some combinations are worse than others, especially the H3N2 virus. which increases the risk of bacterial infections. What's also challenging is that they change very rapidly, so high rates of mutation and gene rearrangement. So the two big challenges there is one, that we do need to repeat flu shots every season because they often change from season to season. And then the other is that within the same season, they can change, which makes the vaccine less effective. And we'll talk about how vaccines are made and why it's so hard to predict what vaccine we need. Influenza B can be divided into two lineages. They don't change much from year to year.
Hello.
Okay. Yeah. They don't change much from year to year, and so that may be one reason that influenza B is less common, because there may be some persistent immunity which lasts longer than just one flu season. So all of this, of course, means that you can have consecutive infection, right? You can have several flu A infections in one season, and you could have a flu A and then a flu B infection as well. There are more types of flu. There's flu C, which is a very mild illness, and then flu D, which doesn't infect humans, so we're not going to hear or focus about them. But unfortunately for us, again, that virus does change, right? So antigenic drift means that mutations in the genes for the various antigen proteins can cause a change in the antigens. And sometimes those are minor, but there's a mismatch with the virus. An antigenic shift is a major change when the virus acquires a new genome segment from another influenza virus. And this genetic reassortment can lead to a brand new type of virus and possibly a pandemic. And we all know that much better now than we did 5 years ago. Okay. So let's move to the other, another myth. So I'm healthy and I don't need to get a flu shot. Again, the numbers would say otherwise. Influenza is an equal opportunity virus. Approximately 10% of children each year have signs and symptoms of influenza. Up to 2,000 or more children in Canada are hospitalized for influenza every year. 20% of those children require ICU care. 5% require mechanical ventilation. And 0.5% of hospitalized patients or hospitalized children with influenza die. Half of the children hospitalized for influenza do not have a chronic condition. And influenza, we know, is very, very, very contagious and easily spread by small droplet transmission, contact with respiratory secretions, and even breathing in the same vicinity can transmit the virus. So transmission can easily take place in crowded areas. Contaminated objects, especially hands. That viral shedding occurs prior to symptoms, similar to many viruses, up to 2 days prior to symptoms. So like most viruses, you are contagious before you even know that you are sick, and certainly before you are sick enough to stay away from others. Viral shedding is also prolonged if you have decreased immunity, which is basically most of my patients, and why we affectionately call them little vectors. So a hint for you for the upcoming holidays is to never eat food offered by an adorable toddler relative, because it might look like a cookie, but it's actually the flu. So there are certainly risk factors for complications, and we've reviewed some of them so far. And again, about half of patients who are hospitalized do have one or more risk factor. So what are the risk factors? Children less than 5 years of age, especially under 2 years of age. Senior citizens, so seniors greater than 65 years. Lung disease, especially asthma and COPD. Heart disease, diabetes and other endocrine diseases. Obesity, various kidney diseases, immunocompromised states. But again, it's not hard to do the math. If half the people have risk factors, half of them don't have any risk factors and yet hospitalized. I know I've mentioned that a couple of times, but I think that's really important to focus for education for our patients. So what's another myth? The myth number 3, it's just a bad cold. So let's talk about what flu really looks like. But first, let's talk about what flu isn't, right? So flu is influenza. Stomach flu is not influenza. And this flu is also not influenza, although grip with an E is influenza. So I learned that when I came to Canada 15 years ago. But I don't spell my name with an E, so we're good there. But the flu is also not just a bad cold, right? The real flu has very high fevers. Viral gastro, or the stomach flu, and respiratory symptoms, or kind of a viral URTI, generally have mild fevers. Right? The real flu starts abruptly, right? The symptoms hit you like a Mack truck. You feel fine, and 10 minutes later, you feel like you've been hit by a truck. Viral gastro and URTIs generally start a bit more gradually. Right? The real flu hurts all over. Viral gastro, URTIs make you feel miserable, but not as much of a hurt all over, head to toe type of feeling. And the real flu doesn't usually have a lot of vomiting or diarrhea, except for in the youngest patients. And that's important just to know, because people will say, I got the flu shot and I still got the flu, when they're really talking about the stomach flu. So just to review, the real flu, abrupt onset of symptoms. High fevers can reach 41 or more. We commonly see 41.5, 41.7 in children with influenza. The fevers themselves, of course, can trigger febrile seizures in the youngest patients, hallucinations, can have a dry cough, nasal congestion, mild rhinorrhea, sore throat, headache, diffuse myalgias, and then prolonged symptoms. So this usually takes a while to clear. In terms of laboratory workup for the flu, again, we do have, of course, rapid testing for the actual virus itself that's positive or negative, not 100% of the time, but most of the time. But general viral testing are usually not very contributory, with the exception of a white count. So, and low white count is generally much more common with the flu than a high white count. So to see someone with influenza symptoms with a white count of 3.6 or 4.2 in the right context, that to me is almost as good as a positive PCR test for confirming influenza. It's important to note that, because if influenza presents with an elevated white count, you should be concerned for a secondary bacterial infection. So let's talk about another case. It's an 8-year-old girl, or 7-year-old girl, with fever and a dry cough. She presents to your ED refusing to walk for 2 days. Okay, does not look toxic, which is a weird pediatric thing, by the way. We always talk about non-toxic appearing. So it doesn't look toxic, doesn't look terribly sick, looks unhappy, but not toxic. She appears well hydrated. Lungs are clear. She's not having any increased work of breathing. When you ask her to walk, she kind of walks on her toes a little bit. And then the calf muscles kind of hurt when they look normal, but they hurt when you squeeze them. You do some blood work and the CK myoglobin is mildly elevated. So time for our next poll. And again, this is a choose all that apply. For Brooke, what would you do? Would you ensure she can hydrate orally, then discharge home? Would you give IV fluid? Would you check a urinalysis? Would you admit to the hospital? And you can do one or more. Well, you can't admit and send her home, but besides that. Let's do another few more seconds. Okay, well, thanks for answering that. We'll end and share the results. So, there, I hope you can see that. So, yeah, so kind of a smattering of results across the board. 32% of you said hydrate orally and discharge home. About 2/3 of you would give IV fluids. 80% of you would check a urine, and about 1/3 of you would admit to the hospital. So, all reasonable answers in theory. I would say in what we would do is, number one, ensure that she can hydrate orally and discharge home. We would not give necessarily IV fluids if she's well hydrated and can tolerate PO. We would not check a urinalysis, and I'll explain why. And we would not admit to the hospital. And I'll stop sharing now and just talk about it a little bit more. And maybe now is actually a good time why, let me, before I forget, I'll mention about the urinalysis. So we know with this particular kind of viral myositis that you can have elevated, mild elevations in CK and myoglobin, but it's not true rhabdo. And so there isn't a risk to the kidneys of this, and true there, even if there's a small amount of myoglobinuria, it doesn't affect the kidneys. So this is a very unique pediatric thing, and it's something that we often get referred to us from outside places. So, but let's talk about Brooke, see what's going on with her. Okay, so let's say, reasonably enough, we see probably, I don't know how many patients a day with this exact same story during influenza season. We sent her home. We ensured that she could take PO, and she was discharged home. Okay. But she has increasing pain in one of her legs. So she returned to emerge, and now she looks unwell, right? She has a high fever, a little bit of, altered level of consciousness. Right calf is swollen, hard red. Her foot is cool to touch. And now we're much more concerned, right? So what happens? My mouth stops working. There we go. Okay. So she's increased. So it comes with this increased pain and quite concerning. So she ends up developing compartment syndrome, it has an emergent fasciotomy, develops necrosis of the distal extremities, requires partial amputation on 3 of the limbs, including her right foot and ankle. So does this mean that we were wrong to send her home? No. Many patients in pediatrics have myositis from influenza. This speaks to the importance of what can happen, though, and the importance of counseling patients about this disease. So what are the complications? The flu is primarily a respiratory virus. So as expected, the most common and dangerous complication is pneumonia, especially with Staph aureus. And Staph aureus is known for causing pneumonia, specifically in influenza, to the point that if we see a Staph aureus pneumonia, we think influenza. And an influenza patient with pneumonia who's unwell, we give different antibiotics as well, or added antibiotics for this, where we may not normally use vancomycin. This is one where we would. The flu, as expected, can also lead to asthma exacerbations. And then from a neuro perspective, again, the flu can cause febrile seizures, can cause encephalopathy. There can be cardiac complications such as myocarditis and pericarditis. And then skin and soft tissue, again, viral myositis is by far the most common complication that we see. If you can call it a complication, we see it so much, I almost feel like it's part of the natural illness. And it's usually benign. The vast majority are. But it can lead to invasive soft tissue infections, and you can have other invasive infections, including of the lungs. One quick slide about viral myositis. It's usually mild and self-limited, almost exclusively involves bilateral calf muscles. And so these patients present often not wanting to walk, and they end up toe walking, right? Because it hurts to put their heel on the ground. It can be triggered by multiple viruses, most commonly influenza. And we have already spoken about the elevations in CK and myoglobin are mild and does not cause kidney damage. Very rarely complicated by invasive infection, and no need for all of those investigations and fluids if the child is taking PO fluids. But again, important to counsel on warning signs. Okay, what's our next myth? Myth number 4, I don't need the flu vaccine. I can just take medicine to make the flu go away. So let's talk about treatment and why it only helps a little bit. We'll start with a quick comment about testing. So we recommend testing only if it affects clinical management. Okay? If you have severe symptoms, patients who are hospitalized, it's important. And sometimes testing can help us to avoid investigations. Obviously, with other viruses that can cause fevers, there are other infections in the differential of fever in young children, but sometimes we can avoid extensive investigations when we're looking at a young child with a fever. Basically, if you're going to treat with antivirals, then test. Okay? And if you're going to test, it's most likely to be positive at the peak of the illness, so about 1 to 4 days after symptoms the onset of symptoms. So there are several types of antivirals, and I won't go into huge detail on these, but one of is the neuraminidase inhibitors. They prevent host cell release of viral particles, and we're most familiar, I think, with Tamiflu or oseltamivir. There are a few others. Zanamivir is another one that's available. That's an inhaled medication, and therefore can trigger reactive airway issues in high-risk populations. And then there's also an IV formulation that's available in Canada, but I haven't heard of anyone giving that. There are some others as well, amantadine, romantadine, which operate a little bit differently. And then there are some other medicines available elsewhere in the world. So essentially, if we're thinking of kind of Tamiflu as the most common one that's used, it does reduce symptoms and complications and hospitalizations and death and shedding. But for the average person, it reduces in symptoms really just by about a day. If you start early enough, it can reduce symptoms by up to about 3 days. But the reason we use that is because of the reduction of complications, hospitalizations, and death. Do we use that for everyone? No, we'll talk about that in a second. Very few side effects, by the way, of these medications, mostly kind of mild GI symptoms. So when to give antiviral medication? So some might say, well, let's give it to everyone with the flu. We would run out of these medications if we would do that. And we do want to know for sure it is the flu before starting it. And the way that we're currently structured is just not, it's about a balance, right? Currently, our ID folks recommend Tamiflu, to start Tamiflu with severe symptoms, kind of high risk for bad outcomes. So immunocompromised, so patients on chemotherapy, for example, chronic respiratory and cardiac issues, including, including ones that we talked about, like asthma, diabetes, patients admitted to the hospital. And some places recommend for all children under 5 years, and some places recommend it for contacts of high-risk patients. So a family that has a young baby in the house that can't be vaccinated, sometimes there. And I think some of that's a case-by-case discussion. But there's a concern for supply, and there's also the concern for the development of resistance, right? We also will start it after the 48-hour mark for really sick patients, just kind of throwing everything but the kitchen sink at them, just trying to do anything possible that can help, maybe even a little bit. Management is essentially supportive, right? It's rest, it's fluids, NSAIDs, acetaminophen. Definitely avoid aspirin. So aspirin is one of the ones implicated in Reye syndrome in combination with influenza. And avoid cough and cold medicines. We actually don't recommend cough and cold medicines for any of our pediatric patients. They don't work. They have dangerous side effects. And certainly we're very supportive of controlling fevers to keep a patient comfortable. But we know that fever itself is not dangerous. Cough and cold medicines can be. And stay home, right? We usually say until no fever for 24 hours. That's a bit of an educated guess on when you're no longer contagious. We don't know that for sure, but generally wait until you're feeling better to go back to school and work. Yeah. Reasons to hospitalize: oxygen requirement, of course, respiratory distress at risk for failure, dehydration, and so forth. And obviously the kind of the retrospectroscope, how many patients have you seen in the throes of the flu who say, oh, I should have gotten the flu vaccine, right? But of course, do this with kindness. This is not the time to judge, but I think people do recognize that this could have been avoided and so forth. So a good question in the chat is, what age can they use cough and cold medicines? Depends on what you read. We actually don't recommend them outside of adolescence. So really, under the older you get, the fewer side effects there are. So certainly between 6 and 12, you'll have fewer side effects than the under 6 crew. But generally, we don't recommend them outside of the adolescent time period. And even then, we don't recommend them, but we don't discourage them necessarily if they want to take it. In some countries, it's actually illegal to market cough and cold medicines for young children. Okay. A question to clarify. So why do we want to avoid ASA? So ASA or aspirin has been associated with Rye syndrome in children under 18, which is fulminant hepatic failure. But we now know that it probably is linked to some underlying as previously undiagnosed metabolic disorder, but it can be very significant and fatal in some cases. And it's been associated particularly with two viruses. One of them is varicella virus and using aspirin, and the other is influenza virus and using aspirin. So that's another one that under the age of 18, we don't recommend aspirin for anything at all. And actually children who are on chronic aspirin for any reason, there are a few of those with cardiac shunts or other reasons, and those are considered high risk for, populations for the flu vaccine, so they don't get the flu vaccine. Or so they don't get influenza while they're on aspirin. Okay, so this next myth, the flu vaccine doesn't work. Well, it does, it really does. And we know it does. Oh, my mouse not working, sorry. Let's go to Caleb. I think I saw one more thing in the chat. Okay, when do you think to give immunomodulation? Yeah, so I don't know the full answer to that. I've never had that come up. Certainly, I've never taken care of a patient with that. And by immunomodulation, certainly there's more things that are available for COVID than are for influenza. I'm going to say that I don't know. But I'll just say that anecdotally in 28 years, I've never seen or heard of someone receiving that. I can find out. So let's talk about Caleb, right? So Caleb's a 6-year-old who came home from the school feeling fine, but suddenly said he didn't feel well and was achy all over. He has dry cough and sniffles, feels hot to touch. Dad gave ibuprofen and put him to bed. Okay. So let's bring up our last poll. What is true about Caleb? Choose all that apply. Okay, so he likely has the stomach flu. He is at high risk for severe illness. If he isn't vaccinated for the flu, it's too late now. And if he had the flu vaccine, his illness is likely to be mild and his risk of hospitalization would be reduced by more than 50%. So we'll end the poll and share the results. Again, 97% of you said, I agree. If he had the flu vaccine this season, his illness is likely to be mild and his risk of hospitalization would be reduced by more than 50%. Right? He does not have the stomach flu. He at the age of 6 could have some vomiting and diarrhea, well, along with influenza, but this is not the stomach flu. He is not particularly at high risk for severe illness because he's over 5, so he's out of that category, but he is still at risk for sure. And if he isn't vaccinated, it's too late now. Nope. We don't know what type of flu he has, but whatever it is, he's at risk for the other type still this particular season. So it's not too late. Okay. So Caleb, he did receive his flu vaccine at the beginning of the winter, and after a few days of feeling yucky, he is feeling much, much better. So they do work, right? For sure the vaccine doesn't work if you don't get it, but if you do get it, it does reduce the risk of hospitalization by more than 40% in adults and 50 to 60% in children in a good coverage year, right? You do need to vaccinate every year, right? And we talked about why that is because of those mutations. But it's also, there's a shorter incubation period, right? So influenza, like COVID, will likely never be completely eliminated. There's some other diseases like polio and smallpox, which we've been able to eliminate from a longer incubation period. But if you do get the flu, you do develop short-term antibodies to that strain, but to that strain only. And the antibodies are only short-term as well. So it's never too late to get the flu vaccine. Effectiveness does vary by year, depending on how sneaky the virus is at trying to mutate. And we spoke earlier about the subtypes changing very rapidly. I think it's helpful to talk about how the flu vaccine is made. So some people say, the flu vaccine is made and you give it in October and by November it doesn't work. Well, as most of you or all of you realize, it takes time to make vaccines, right? This is not a several week or even several month process. So the decision about what subtypes and lineages to include in the flu vaccine, those decisions are made in February, March of each year for the Northern Hemisphere. They look at the Southern Hemisphere. They say, what's the Southern Hemisphere seeing right now? And they use that. It's an educated guess in terms of what vaccines may be affecting the Northern Hemisphere. Right? So the vaccine does take about 6 months to make. So really, it's that predictive model and a highly educated guess, but still a guess no matter what. And we know the virus can change a lot. So it does, no matter what, decrease your risk of catching the flu, and if you do get the flu, it's more likely to be a mild illness. So what would happen if everyone got the flu vaccine? Well, let's look at the benefits of those who did get the vaccine, right? So in the US during the 2019-2020 season, so just prior to the pandemic, it's estimated that flu vaccines prevented 7.5 million illnesses, 3.7 million doctor visits, 105,000 hospital stays, and over 6,000 deaths. So while we focus on the deaths, every one of us knows, every one of us who is a healthcare provider, when we all are, to prevent illnesses, to prevent doctor visits, to prevent hospital stays. I mean, think of the impact on the healthcare system alone by preventing more and more infections. So my final myths, right? The flu vaccine is dangerous. No, it isn't dangerous. The flu shot can give me the flu. No, it can't. So there are two types of available vaccines, and most people do get the injectable vaccine, which is inactivated and simply cannot give you the flu. It's impossible. There is an intranasal vaccine, which is live attenuated, very difficult to get influenza from that vaccine, but does have a few contraindications. And the intranasal vaccine hasn't been shown to be more effective than the intramuscular vaccine. It does have some contraindications, as mentioned, severe allergy, immunocompromised, pregnancy, asthma or COPD, because just injecting anything up the nose can trigger problems there. CSF leak, or people at risk for a CSF leak, like those with cochlear implants. Recent antiviral infection, because that can inactivate the vaccine. I'll also mention that children from 6 months, when they can first get a flu vaccine, through the age of 8, if it's their first year getting the vaccine, they need 2 vaccines a month apart. Okay. As for side effects, reactions in general are mild. They can have a low-grade fever and muscle aches. And we sometimes see this as a reaction to other vaccines as well, right? So it's simply a sign that the body is producing antibodies against the flu, just like we want it to. It's not getting the flu from the vaccine. Are there more serious side effects? Certainly. One known side effect is Guillain-Barré syndrome, estimated to be about 1 in a million. But there's a risk of Guillain-Barré from influenza disease, right? So we always have to balance those risks and benefits. So just kind of wrapping up, in summary, let's review what is true. We've reviewed some of the myths. Let's review what is true. Truth number 1, the flu can be very, very serious. Healthy people should all receive the flu vaccine. The flu is much more than a bad cold. Prevention is much better than treatment. The flu vaccine does work. The flu vaccine is safe. And the flu shot cannot give you the flu. So ultimately, we shouldn't think of it as getting a flu shot, but think of it as this young man does, installing virus protection software. So I'll close with this slide. What did you see and hear today that struck you the most, and what will be important for you to do to make this real.